Excellent. Thank you, Michelle. Like we mentioned, uh, this is a four-part webinar series, and we today will be covering module three of our of the whole curriculum that we have developed towards clinical applications, uh, working with Hispanic and Latino populations. Uh, without any furthermore, I leave you with Dr. Michelle Evans.
Angel, you can hear me and you can see the PowerPoint? Well,
Yeah,
okay,
all good to go.
wonderful. Wonderful. Thank you so much. Well, welcome to everybody. I'm so glad that you could join us today. I've taught, there's many different modules in this clinical applications training. And this happens to be one of my favorites because it really does talk about just how we see illness. When we're talking about illness, when we're talking about problems of life, problems with living, as Sullivan might say, this training really talks about those little things that sometimes can affect our diagnosis, can affect our assessment, can even affect how we look at the process of helping. And so I'm really excited to be able to talk to you about this and just share, how we can understand culture when we're understanding illness in itself. So let's see here. All right. And so I know Angel went over some of these items. And there are no conflicts to disclose. So here we go. So some of our learning objectives for today. This module in particular will provide training on integrating cultural factors into school mental health services and mental health services in general. We're going to define and identify major concepts of distress among Hispanic and Latino students. We're going to discuss cultural concepts of distress unique to Hispanic and Latino cultures and apply concepts of distress and create culturally relevant treatment plans. And so as we're thinking about this, I want to start with a little story that I have from the other day. The other day I went to the doctor, and the doctor, in doing the general triage assessment, asked the wonderful question of, are there any religious or cultural issues that we should consider in the provision of your treatment? Now, I've done a lot of these cultural competence trainings. And so I thought about that question and I'm like, well, of course, which instantly, of course, stops them. And they're like, well, what? And I'm like, well, it depends. It depends on who's seeing me. In other words, if I have a treatment provider who is very, very different than I am, maybe doesn't even speak English, or so it's hard to understand, or maybe they see medicine or see illness differently than I do, there's going to be a cultural issue, but I don't know what that's going to be until I actually meet my treatment provider. And so in thinking about that exchange, and so the treatment provider and I had a moment, they were looking at me confused. Again, it was a regular appointment and they weren't expecting that. But I began to think about that a little bit more, and I think about how we always, whenever we're assessing clients, we now often ask those sort of questions of, do you require any religious, or cultural, is there something we should know so that we can best serve you? And when looking at that, it is very, very dependent on the specific provider, healthcare provider and the client and how they integrate. And so when I'm looking at a larger healthcare organization, how am I, culturally or religiously different than that organization? Much more difficult to say. That's and probably not even useful. I'm really looking at that individual person as they treat me. What is their perspective? How do they look at illness? And that's some of what we're going to talk about today. But as you're starting to prepare to watch this webinar, I really encourage you to really come back to thinking about you as a care provider, and I see we have a lot of different people from a lot of different areas across the country, and I'm certain from a lot of different places and a lot of different treatment areas, whether it's agency, outpatient, inpatient, maybe not mental health at all, maybe school, and so we have many, many different people, and so these things that we're talking about today will apply to us differently depending on the individual that we're looking at. And so moving forward. So the concept of illness, when we think about what is illness, we live in an age, especially using Western medicine, that defines illness based on what is going wrong. It's actually a stigmatized term. When we think about individuals with mental health issues, problems with living, depression, when we're looking at just even the difficulties of acclimating to social environments that, in different contexts. We have words for illness or disorders that are very stigmatizing, and so in trying to develop a cultural understanding of this, we have to go back to exactly what is illness. And so I'd like to, I'll give you that question just to think about for a minute of what is illness? Is it the absence of health? Is illness a disorder in symptoms? Is it just anything that happens to impact your functioning? Because this is very important, and your definition of illness comes from your specific culture and how you've grown with it. If you grew up in a home where illness was something bad, don't get a cold, and often, there were a lot of attributions of how you could get sick, who was sick, oh, well, that person, they're ill. Typically when people hear other people are ill, especially in today's day, oh, we want to stay away from them. And that's how we see illness. And so these are really related to our culture, who we are, how we see life, and how we see health as well. It's a dichotomy of terms. And so as we think about understanding illness, cultural concepts are embedded in that. And they may be related to acculturation, discrimination, oppression, and stigma, also related to substance use and mental illness. Even substance use. I know often I talk to my clients who might be coming in, and asking me just about, well, do I have a problem? So I do outpatient treatment with individuals who have addictions, specifically, often sex addictions is my specialty, but also working with individuals that have drug addictions and mental health issues, because often those are all kind of combined together. And they, and often I'll have a client who's like, well, doc, do I have a problem? Leaving it to my judgment. And the question is, that I always ask is, well, if your behavior causes you a problem, then you might have a problem. But even, I don't necessarily even like that terminology. I use that because that's what's, the understandable. But, as we're talking about what illness is it just problems? And as we talk about it, as we use, we've been, SAMHSA's been, really pushing, talking about person first language. And that's really the standard now in our healthcare field. How do we talk about it? Instead of someone with, a schizophrenic, someone with schizophrenia, where it can't be a label anymore. Illness cannot be a label. It has to be a descriptor of something someone's experiencing in their life journey, which makes it much less stigmatized. But we'll get into this. And so as we're looking, different understandings can come from just how we've talked about it during our own lives. And so as we think about the impact of cultural values on illness, so first of all, I want to step back, and if you were here in the classroom with me, I would ask you, what are values? Often when I ask that question in a class, people tell me what they value. Well, I value my family. Well, I value my house. Well, I value, all these different things. And I like to put that, because I like to put aside the noun of what I value, as a noun, and look at the, what are my values in terms of my verb or my descriptor. In other words, I value independence. I personally value responsibility. And so when I make a decision, the way values come into that making that decision are, I go forward to determine which one is more, which one do I value more. For instance, if I have $10 and, on one hand, I have a friend who's really short on cash, and I could, but I know she also hasn't decided to work. She kind of sits, but she needs some cash, but isn't really a working person. On the other hand, I'm really worn out and I need some self-care, so that I can be my best person, so I also have the choice to use that $10. There are definitely people that would say, what, you should help out your friend, even though, maybe your friend didn't help their own situation. You should still help a friend. And, instead of selfishly taking it for yourself. Other people might say, you know what, just like in the airplane, you got to put your own mask on first. You need that self-care. And that will help you better help your friend and maybe help her get a job or help her kind of get back on her feet so she can provide for herself. Neither answer is wrong. Both are based on values. Do I value responsibility? Do I value self-care? Do I value altruism? Do I value, relaxation and independence? All of those values, if you and I, let's say, were arguing this, of which I should do with my $10, those values would come into play and would dictate our priorities for this $10. And so as we think about cultural values on illness, and we think about how our clients walk in the door and tell us that, hey, this is important to me. And sometimes in our own, we have our own values and bias regarding offering healthcare. We're looking and going, you're completely wrong. You just don't understand how important this is. And our clients are looking at us going, no, that's not I don't value that. That's not part of my values in my life. And so therefore we have kind of a disconnection between the treatment provider and the family. And so when we look at Hispanic and Latino populations, the cultural values of familismo, machismo, and personalismo have been found to impact interpersonal and intrapersonal behaviors. Familismo or familism is a concept which emphasizes an individual's dedication to the family above the needs of an individual. Recently, I've been working with a man who is, recently had a heart attack within the last year, continues to struggle with diabetes. And we've talked a lot in our sessions. He's here for mental health reasons, but in talking with him, he has shared with me, he always looks just so fatigued, worn out. And, in talking to him about that, he's like, I need to go to the doctor and get my medication adjusted. However, I have kids in college and I need to contribute to helping them, while they're in college. And I'm sitting here and going, don't mess with your health. You need to put that money into, attending your doctor's appointments. But in talking to him, that's not where his values are. His values are, in terms of the money he's spending, my family is the most important thing to me. If I'm going to spend money, I'm going to spend it on my kids' college education. I'm going to spend it on taking care of them because that's where my priority is. And so we've gone through many, many weeks of this. And finally, to adapt his treatment, because I recognize this value was so strong, I wasn't budging that. I was not going to get him to see his medical doctor. And so instead, we moved toward talking about how to improve his health through healthy eating. Through some of the other behaviors, exercising, relaxing, taking rest, dealing with stress. And that he was totally, totally open for, because he had the time and, even seemingly would save him some money if he did start eating better. He's diabetic and drinking like 6 Cokes a day. So that was our first target. And so in looking at that, it required me to adapt what my values were of, hey, your health is incredibly important. You know what? Your family will figure it out. But if you're not alive, you're not going to be able to take care of your family. But his values were different than mine, so I had to adjust. And so even in looking at illness, and talking to him about, you are ill, you have this illness, we had to start to come to an agreement of exactly what that meant for him in his life. So talking a little bit more about what these are. So this is one of my favorites, machismo. And I don't think I didn't give you the opposite. So machismo within our social world is often used mistakenly. So machismo is a concept that may also positively or negatively impact a client's perception of suffering. It may either encourage courage and strength in the need for responsibility to care for the family, or it may isolate the individual through their belief that they need to dominate others and to not demonstrate vulnerability. And so the female form of machismo is marianismo, and there is this, within this culture, there is this nice balance of being nurturing and caring versus, being a protector, and so when machismo is used as a value, within a Hispanic or Latino family, it is seen as a good thing. I am the protector. I care for my family. I make sure they have what they need. I'm a provider. And so it can be very, very helpful. In fact, in the case I was just talking to you about, we used many of those values of understanding, all right, in your frame of reference, in your values, you are a provider for your family. And that comes first before all else. And it was discovering that and seeing how machismo is playing out in his life as he considers what he needs to do in terms of his own health. However, on the opposite side, it also was inhibiting his communication with his family, because he was interpreting his, machismo as, do it all yourself, take care of it, just keep going forward, you have to be strong. And beginning to feel very lonely and very depressed in this because he felt that he had to do it all himself. And so some of our work, it started to actually reach into the one right below, which is personalismo, and looking at his personal relationships and starting to identify how he could use those personal relationships better to help support him, in carrying this great load of caring for his family while he had a health condition. And so being able to interpret it and understanding that, okay, he does work with these personal relationships. And even in the therapeutic relationship, I had to lean much more into that, developing a personal relationship as opposed to, being the expert, making a recommendation, so that he could move forward. And so using these values really allowed him to move forward, and to a place of where he trusts me. And he sees that, okay, I can take his values and also integrate them so that he is, so he's able to meet all of his needs. So some possible beliefs regarding mental illness, substance abuse disorders, and treatment. The values of Latino family may be used as support or a risk factor in the treatment of mental health and substance use disorders, as I've been giving you that example. Another example is if you have a student who has harmed his family due to mental illness and drug use, he may be alienated and struggle to access resources due to sociological barriers. However, if his family agrees to provide support, this may be a great strength. And so in talking about, I'll give you another example, in talking about some of our adolescents. I work with adolescents. I have an adolescent group that works with adolescents who, have demonstrated sexual behavior. And just about all of them have gone through court. And so for an adolescent, they have gone through probably one of the worst experiences of their life of having to talk about, inappropriate sexual behavior, not just in front of their parents, but also in front of the court of law. And often, with that tucked into some of those behaviors are other issues, such as mental issues with mental health, sometimes substance use, sometimes other personality issues, or other, depression, etc., that are impacting them. And as I look to work with this adolescent and start to assess the sociological impact, I'm looking at the values that we just talked about, and looking at, we have some parents who may, highly value that personalismo, that connection with treatment providers or the connection with teachers, but we may have a differently acculturated adolescent who is not, who's having a hard time interacting with their parents and accepting their parents' recommendation because of the values difference regarding illness and how it's treated. And so I've had more than one family session with an adolescent who, was a native English speaker, and parents who are native Spanish speakers, and even helping them communicate because the vocabulary is different. The native English speaking adolescent may not be able to express themselves well in Spanish, in terms of their emotions and how they're feeling about things and difficult topics. And the native Spanish speaking parents may not be able to understand all of the different elements that we're looking for. And then again, they might be working on a different value system based on their own growing up experiences and how they look at illness. And so often the adolescent, feels that, hey, my friends are doing it, this is just what's happening, or mental illness, this is just how life is. And the parents may or may not have the resources or understanding to be able to fully meet their needs in especially a school environment. And this is where often family therapy, outreach by the school counselor can significantly help the adolescent and the family come together to help them develop a common language to be used. And so when we think about school systems and youth academic performance, we know that when we're looking at issues that are happening in school, it is not just a school issue. One thing I tell my clients all the time is how you do anything is how you do everything. Most of them have a little bit of pause of that. And they're like, I'm not this, I'm totally different when I'm at school. And they're like, well, no. And so if you're familiar with cognitive behavioral therapy, often the thinking errors, the cognitive distortions and our core beliefs are always in there. They don't change when we go somewhere else. And so if I have the core belief that I am no good, the way that core belief may show in my house, in terms of isolating, not being motivated, arguing, irritability, may be completely different in a school environment where maybe my feelings of not being good enough are, maybe I'm a show off, maybe I bully other kids. And so as we're seeing, and we're trying to, if we're in the school environment, working as school counselors, or even if we're an outpatient working with adolescents and looking at how their school performance is, it's looking in that and going, okay, the same issue that might be causing problems in the family and at the school are coming from the exact same thinking process if we're using a treatment such as CBT. And so our job is really to get to the center of it, to look at that adolescent's thinking processes. How are they understanding their world? How are they understanding themselves, and how are they learning to identify themselves? So that we can begin to help heal both sides, and teach them better ways to cope, with perhaps issues of mental health or issues with self-esteem. Hispanic and Latino children and families may experience high levels of stress before starting school, especially when we're looking at a family who may have different acculturation levels, or even that haven't come into, our school systems. Latino youth present higher dropout rates. Some of the factors or behaviors that may contribute could include, and you can see here, cutting classes, suspensions, dating constantly, being older for their grade, being female. When we look at just the disparity of services, and I think this is so important, especially right now. It's always been important, but today is today. We have, it's super important, especially, and I'm thinking of our pandemic currently. As we're looking at just the disparate resources they have in the community, the ability to access services. And then we're also looking at the ability of the parents who, in terms of do they have an awareness of the services that are available? Are they able to drive individuals to appointments? Are they able to consistently express themselves to treatment providers? And if the treatment providers aren't familiar with the culture or the socioeconomic issues that this adolescent may face, right there, you may have a disconnect between the treatment provider that's trying to work with either the family or the adolescent, and maybe recommending things that are just inappropriate for either the individual's circumstance, or there's a lack of understanding. They may be recommending something, but if the family isn't understanding why, or it doesn't align with their values, it's highly unlikely that they're going to continue the intervention in a meaningful way after the treatment provider has made those recommendations. And so these particular things, when we see this coming up with adolescents, these are number one, risk factor of going, okay, I see these things happening. This adolescent, we have to put, on a higher risk level because we see these things. I think it's really important in our work that we start to move toward instead of using our clinical judgment's important, don't get me wrong, but best practice happens when we use our clinical judgment plus evidence, evidence-based research, plus the needs of the patient, adapting it to that specific patient. When we have that triangle, that's what really provides us with best practice. And so therefore, that's my recommendation as we look at things like this, in terms of, these are literally risk factors. And as you're walking into a situation, working with an adolescent or even a family, or younger children as well, it's making sure that you're taking that into, okay, well, this is what the research is showing. And so using my clinical judgment, it's important I pay attention to that. I work a lot with individuals with sexual addictions and who have sexual behavior problems as well. And I'm looking at that number 3 there, dating constantly, is one that I think that we often miss. Often we see individuals who literally are dating constantly. There's somebody new every day. I'm thinking of a client I have who, they're at the beginning of a group, we always go, okay, what's your high and what's your low? And I think 3 weeks in a row, he's met a new girl. He's on my radar, because it's like, wow, every single day, every single week, you have somebody new that you are wanting to date. What does that mean about his identity? What does that mean about his ability to connect? What does that mean about his ability to share with other individuals in an intimate way? And so I'm looking at that certainly. It can also, some other things that can affect students' mental health and academic performance are, migration stress, acculturative stress, discrimination, poverty, cultural learning styles, socio-emotional readiness for starting school, linguistic and cultural marginality, deportation, of course, separation, and reunification. I think it's so important that when we work with this population, with the Latino and Hispanic and Latino population, that we don't assume. And sometimes I've found, in working with some students, I've found that they have challenges in asking the question of, can you tell me about, can you tell me about, where you've lived during your childhood? Can you tell me about your family's history? Can you tell me about just your immigration process? What was that like for you? What do you feel when you're talking about these things? Even assessing what are the learning styles. I know often clients come in and we assume they can read. We hand them the paperwork and we assume they can read in English, perhaps. Well, if they speak good enough English, well then here, I'll just give them all the forms in English because it's easier for me or easier for my intake staff. And so we have to be very, very careful not to assume based on, the face value, any of these issues. Recently, I've been working with some adolescents that they speak English perfectly, very barely an accent. And I've recognized that these questions aren't coming to me as easily because of my own bias of, well, if they're speaking English fluently, even though I know they speak another language, they must be fine. They must be fully acculturated into the population of the US. And then when I, start to ask more questions, I find no, there's actually a double life there, that they're able to present themselves very well, with, very good English, participating in school activities, very well connected. But when they go home, there's a whole different life. And I think it's very important because, and they've learned to do this because sometimes of the stigma, because, being their selves, how they are at home, how they act, their cultural norms, their values, it doesn't fit into their school life. It doesn't fit into their friends. And so they're constantly adapting themselves, which does impact just their identity and how they see themselves. And so these really need to be looked into, and we have to be open to those conversations as individuals are able, and willing to talk about them. Discussing, and so within that we have unaccompanied migrant children. So under US law, unaccompanied alien children are defined as migrants under 18 years old with no lawful status in the US and who have no parent or legal guardian available to care for them. There's been a recent increase in the number of unaccompanied migrant children crossing the border of the US from Guatemala, Honduras, El Salvador, and Mexico. I know I work up in the Chicagoland area, and multiple times I've had individuals who fit under this. And so, especially if you're in the southern half of the United States, you may be working with this much more, within your schools. I know up here in Chicago, which is also, a migration point, many people do enter the Chicagoland area, but often those children are being transported alone, where they're coming up to meet with an aunt, a brother, a sister who's already here in the Chicagoland area. And so, but when I meet them, usually they're with their family. They're working with me. They're usually involved in the court system in some way, due to a criminal action, not due to immigration issues. And so if I'm not attentive in talking to them just about their experience, and being open for those conversations, I can miss some of the significant trauma that they may have experienced and that may be impacting their mental health. And especially in school systems, I know one of the flags that I've begun to learn is asking the individual, if I'm working with an adolescent, asking them about their school history. How many schools have you attended? Did you ever not attend school? For how long? Why weren't you attending school? And that can often give me some data points as to what this individual has experienced through their life, so that I can better help them. All right. How about that? All right. So give me 1 second here. I wasn't expecting the end of that. All right. If you can excuse me for 1 second.
It seems Michelle lost connection because we lost her visuals as well. We're gonna make sure to establish connection with her and we'll be back in a second. Just give us a few minutes.
We are reaching Dr. Evans through the phone as we speak. She will be connecting just in a second. Thank you for holding and sorry for the inconvenience.
All right, I am so sorry about that. Can you hear me?
Yeah, we can hear you.
Wonderful. Okay, so I am so sorry about that. I had a glitch with my PowerPoint there, and so I do apologize for the inconvenience. But now we can go forward. So thank you for your patience. All right, so where we had left off, we were talking about, we went through this slide. And so as we're looking at, unaccompanied migrant children, there are a lot of stressors regarding migration, which means mental health symptoms, and often just based on trauma. Within the migration experience comes an element of having to separate from either your family, your family that you're leaving back home, from your native country, but even going into a new place, and the loss of culture, the loss of connection. Undocumented status in itself has been shown to increase fear and isolation and negatively affect mental health. And some of this is that not having that feeling of belonging. We see this a lot in when we're looking at underrepresented and oppressed populations, of just feeling that difference. Human beings were created to connect. And so when we find that there are issues that an individual is having in connecting with others, with their peer group, with their families, and with others that are in their world, we can see, the issue. So. Yeah, do you see me? Sorry, I'm on right now. Bye. Sorry about one of my helpers here just called. I thought there was something wrong. So, all right. And so in terms of unaccompanied migrant children experiences, These are some of the things that they may be experiencing, facing other traumatic events, hardships that they faced in their country of origin. We're looking at train rides, robberies, assaults, intimidation, coercion or abuse by adults, kidnapping, sexual violence, exposure to the elements, harassment and bribery, hunger, thirst, exhaustion, separation from family, loss of community, uncertainty about the future, and detention. And this is the experience in traveling. And then we think about their experiences once they start entering, whether it's the school environment, whether it's the community that they're in. And these issues continue, because they're individuals who, immigrants, and especially migrant children, are often put into positions where they don't have people to reach out to. And it might be due to a language barrier. If they're in a school where there isn't sufficient ability to communicate, there's, maybe it's primarily English speaking, or there aren't enough Spanish speaking staff. If they're in a bad situation, they cannot reach out. Additionally, if the child is in a situation where, perhaps they have a lot of support, but they're learning the culture as they're here. They're learning how to interact with other children, other peers. And especially if they're older than their peers, there can be a continuation of just that loss of community, issues with separation from the family. And so the trauma may not stop once they are, shall we say, safely with their family, their neighbors, or whoever they're moving to. We often also see migrant children working earlier, and thus not continuing in school at all. And so we see a lot of the exact same issues that, that poverty brings, that, of just early pregnancy, early marriage, ongoing poverty, lack of achievement, lack of ability to move forward in jobs. And so this can continue for possibly, the lifespan if there are mental health issues that are not treated appropriately. In entering the school system, there's additional challenges, just being unfamiliar with school routines and expectations. If you've ever worked in a school, schools have their own culture, how we do things, school spirit, how we interact, how we relate to other students, what teachers expect, and so if that's unfamiliar, it can be very difficult. They may be placed in a classroom based on age that doesn't correspond to their skill or experience level. And so therefore, if you have a child who based on age is in, let's say, the 10th grade, but they've missed school for the last 2 years, we're setting them up to fail, just because there are certain things that they won't know about, and and therefore they're already starting on that bad foot of not knowing how to answer, not knowing, the foundational information that they might have needed. First experiences such as eating new foods at lunch, taking a school bus, and they may be experiencing these alone if they don't have other, peers, family, cousins, etc., to orient them to these things. And it may be difficult to talk about with your family as well. Talking about your experiences at school with your family when you come home, they may or may not be able to relate. Also, the experience of discrimination, teasing, bullying by other children at school due to their appearance, culture, religion, beliefs, or language. And these things, these are within our schools on a normal day, but even more so, for someone that is migrating into our system. And then our trauma-related mental health symptoms. They may experience trauma-related mental health symptoms, which can be exacerbated in a setting with authority figures. And so remember, the helps, are children who have grown up within the US school system, let's say, know how things work, know who the helpers are, know what a school counselor is, know what a principal is. But if you're coming from an environment where, where the metaphor about leadership and power is that they're not out to help you. In fact, they could harm you. Looking at their metaphors, that were happening in their country of origin, and how now they're working in a school setting where, reaching out for help can be difficult, if you don't know, who to go to for what. This is where, as we think about, a little while ago, I was talking about the values of personalismo. I've experienced myself, and I know many of my colleagues have, of, once you start to work with a family, that you may be their number one person for everything else as well. And some of that, is because of that large cultural value of that connection, of that being, being personal, to be able to work on some of the issues that they're facing. And so the Oklahoma State University study included a general population sample of Latino 7th grade students in an urban public school district in the South Central United States. This study examined the relationship between an immigration-related arrest of a family and depressive symptoms, and found 29% of the students reported an immigration-related arrest of a family member. And Latino youth who experienced an immigration-related arrest of a family member reported significantly higher depressive symptoms than youth who did not. As we look at, if you've done any study, any work with trauma, and we look at what trauma does to individuals, and it may be just a one-time experience, but what we found is memory is like concrete when there's an emotion attached to it. There's so many things that I forget. Where are my keys? What did I do there? How in the world did I end up here? I completely forgot my drive home. So many things that we forget. However, if we add a little bit of embarrassment, a little bit of shame, a little bit of fear to that memory, it is in our minds like concrete. And it's very, very hard to move on. And these experiences form our narrative of how the world is. And so when we're looking at children and how they learn about their experiences, when we look at children and how they develop this sense of identity of who am I and who are the individuals in my life that are going to help me, these experiences, even if they're very few and far between, they get put into that individual's understanding of how the world works. And so as they grow up, we may see these same children as adults and continuing to experience just the after effects of this trauma, because of some of the things they experienced in early childhood. And so therefore, as we're thinking about working with children, and we're always also working with their parents. And it's notable to also say that their parents have often gone through this as well. Often their parents are, similarly, these individuals who have gone through either an immigration-related arrest themselves or seen it happen to their families. When we're looking at generations of individuals who have been going, from their country of origin to the United States and then back, we can see that there can be many, many different layers of generational trauma that we're dealing with, not just the trauma that the individual child has experienced, which can affect how families work together. So then when we're looking at reunification, one of the things, so I mentioned a little earlier, I'm in the Chicagoland area, and particularly in a large suburb that is, I think it's like 85% Hispanic and Latino. And therefore, on any given day in working with students, we have the back and forth of parents leaving, parents needing to go, move somewhere else due to work. Also children coming in, family members coming up to the United States to live with the grandparents and the child, or the child returning to Mexico to live with the grandparents or whoever else for a while. And so we see this constant both separation and reunification often, based on the family's needs. I recently have been working with a lot of individuals, a lot of immigrants who are, they have families here, but they are working out of state. And so they go out of state for 2 weeks, they work, and then they come back. And we're seeing just this repeated trauma and stress of separation, because there was the initial stress from the children of, they were separated when their parents came to the United States. And now, again, because of looking for work, they're again having that experience of separation over and over and over again, which really is impacting their understanding of identity and how the world works. And so when we're looking at reunification, we can see disruptions in attachment. And, our attachment theory teaches us that children learn how to attach to other people early on in childhood. And so if the attachment's disruptive, if that child learns that, when your caregiver loves you, they have to leave, they're going to leave you for a period of time that nobody knows, they can't tell you when they're returning, and so that just continues. And then we see them growing up, and we start to see some of the effects of that, even moving into their own ability to attach to their children as they grow up. There can be a lack of familiarity and connection with caregivers. I have interpreted more family sessions than I'd like to name, because we have a teenager who speaks English, native language English, is committed to speaking English, and the parents who don't speak a lot of English. and so it's trying to develop that language, and how are we going to speak to each other? Because often, when they're trying to communicate, both with a little bit of each language, they don't do it well, and so a lot of misunderstandings ensue, and they don't have that relational connection to kind of lean upon when there are misunderstandings. Relationships are like a bank. You have to keep putting stuff in, and if you're not around, if the parents aren't here, aren't with the child to be able to kind of make contributions to that bank, it's really difficult when they do get here and all of a sudden there's differences in opinion as to priorities and the expectations of the child. The caregivers may have limited parenting experience or knowledge of child development. If all of the parenting has been done, via Facebook or Zoom or whatever, that can be very difficult. And all of a sudden we see changing roles within the family. Difficulty trusting caregivers, stress in caregiver-child relationship, limited resources. There's often not enough money for family sessions, and resources are difficult to come by, especially if we're in an area that is already impoverished. Fear of deportation or legal involvement. Often if the family members are here, that doesn't mean that the paperwork is ready. It may just mean that, well, we're here now, but you can be deported at any time. And then the discoveries that parents may have a new family. I know this can be very, very disruptive. When the parents maybe leave, a couple of children behind with grandparents and then come up and continue to have children. And so now there are children that have been living with the family, with the parents for, 3-4 years. And now you have these children, that are coming up to the United States who are just like joining this new family, but it's their parents, and that dynamic, and who's actually the oldest. At this point, the first child to be born in the US may have been the oldest for several years, and now they find out they have 3 older siblings that are now in the house, and we're working on those dynamics. Who's the barn boss? And so caregivers are unable to understand or relate to the undocumented migrant child experience. Expectations of the US and an idealistic image of family that doesn't match reality. Especially if the family has, watched a lot of movies, a lot of TV, if this is how families work. As with most of us, when we're seeing other images, the Joneses and social media, it always is a little bit greener on the other side. And then all of a sudden when we're here in reality, it isn't the same. And so that takes some adjustment. And so how can providers enhance their cultural competence? And so in this in particular, it applies to working with children, but it also applies to working with anybody, really. Children are just, little humans, but we work the same way. You can quote me on that. And so we have to read basic information about the unaccompanied migrant child's country and culture of origin. When working in cultural, I like to use the word cultural humility. Cultural competence implies that I can get good at it. That I can be competent, as I see it. And I really like to, more push that cultural humility. Kind of like when I started this conversation, today, of talking about how in the world can I know if there's any cultural or religious accommodations that I need if I don't know who the healthcare provider is. How does that work? Maybe, we might have differences, we might not. But until I actually meet that person, I don't know. And so similarly, as we are sitting there, we can, it's good to read information, just about what the individual might have been might have been dealing with. That's part of that evidence-based information, evidence-based facts that we're looking at. I have my clinical judgment of, I've worked with this, client before, with children before, maybe with migrant children before. But then we're looking at that, at that adapting to the specific patient. And that's the part that without working with the actual individual, we don't have that triangle of best practice yet, and so, but that's a great start, just reading, acknowledging the difficulties that unaccompanied migrant children and their families have experienced, having that cultural humility of, even though you may have studied, you may have worked with migrant children before, having that humility of, well, I don't know everything and I don't know about your experience. One thing I like to tell my clients is that they are the world galactic expert. Oh yes, galactic expert of themselves and their own experience. I've read a lot of books and talked to a lot of people. And in that, understanding their difficulties requires a conversation and a humility on my part of, first of all, not knowing everything, but also not knowing their particular individual and family culture. which is where I have to pause and hear them to understand where they're coming from. Also learning about the community where the unaccompanied migrant children live and develop relationships with the community providers so you can provide a coordinated response. We can't, as care providers, whatever area of the field you are in, we still can't do this ourselves. It's impossible. I know I was working with a new therapist not too long ago, and she was actually Muslim, so not Hispanic or Latino. And I found she had the most beautiful therapeutic setup in her outpatient office, which was that it was a treatment geared toward Muslim individuals. She was Muslim. She was a Muslim counselor, but then they would bring in the imam to help with couples therapy, to advise on certain cases, and the clinicians in this agency would go and talk to the imam just about what that person felt was recommended, according to the spiritual law. And I just marveled at that, because I'm like, that's how it's supposed to be, because we have our own areas of expertise, but we need to be able to work within the schools, or vice versa. If you're working in the schools, we need to be able to work with outpatient providers. We can't just sit in our own silos in our office and expect to be able to provide good care, and so that was just a good example of things that we can do to provide that coordinated response. And especially if you're in a migrant community, there can be many individuals that are in and out and changing individuals, and so having a group to help you, is so important. And then understand their basic needs and help leverage resources in order to meet these needs. I know often understanding my own privilege and what I feel is a need, and helping the family define their basic needs, and then helping them with that, I think is so important. And especially if we have not been, in their circumstance, and, we're not in their family, certainly helping them identify what they need, from their perspective is very, very important. Continuing, providing culturally and linguistically sensitive services by using cultural brokers or interpreters when possible. And so I always like to say that the interpreter is not for the client. The interpreter is for us. So when we think about working with, and I often have the circumstance where people are like, well, this individual speaks Spanish, do we need an interpreter? At what point should we get an interpreter? And I think that also always depends on, I don't speak the language of the client, but I look at the default language in our relationship as the client's language, as opposed to thinking the default language is my native language. And often I think we don't do that very well in schools and healthcare, and mental health organizations, because we assume that the interpreter is for the client, that the default language is my language, English, and so therefore we have to accommodate for the client. When we shift how we look at that, all of a sudden our understanding of culture changes, because if I'm getting an interpreter for me because I have the deficit of not being able to speak the client's language, all of a sudden it refocuses that everything we're doing is for the client, and so I want to make sure the client has an interpreter so they can effectively understand me. Yes, I get the benefit of the interpreter so I can understand them, but it's very important if someone's coming for treatment that they can understand, what I'm recommending, or they can understand the treatment that we're providing, and so that's kind of how I look at it, that the cultural adaptation for anything, it has to start with me adapting to the client, not teaching the client how to adapt to me. So also we have to make efforts to learn and respect unaccompanied migrant children's understandings of symptoms and healing. And this in a minute or two, I'm going to talk a little bit about the idioms of distress and understanding how they define that. And remember that unaccompanied migrant children's situation are often tenuous due to their legal circumstances. Be aware of how this might affect treatment goals and interventions. So I have a little triage model that I use when I provide treatment. This helps me, especially when you get a client who has all these different issues. You have social issues, you have mental health issues, you have family issues. And so the triage method that I use is, first of all, in treatment, and the first thing I teach, or the first thing I assess is life and safety issues. Is this client telling me they're going to hurt themselves or someone else? If that, then I must act, based on that. The second thing I treat is issues that may be a barrier to effective treatment. because, you know, theoretically, if there are barriers affecting, you know, that are stopping us from providing effective treatment, then anything I say after that is not going to be effective. And so if there's a cultural barrier, there's a language barrier, if there's a cultural barrier that I just don't understand where the client's coming from, or I don't understand the values, or maybe there's an issue on my end that I'm feeling some bias or misunderstanding, that has to be resolved first before we move into the third thing, which is the quality of life, you know, of looking at issues of quality of life, you know. And so we have life and safety issues affecting the success of therapy. And then the third one is the quality of life issues, usually the reasons why they came there, you know. And then the fourth thing is anything else. You know, in other words, if you have a client who's like, yeah, I'm here for therapy for depression, but I'd love to go back to school. Okay, you know, so that number 4 thing is, let me help you, let me refer you to, you know, a college in the area, or let's talk about the process to get into school, or whatever you need. You know, and so using that really does help think about culture as that number 2. You know, after we've dealt with health and safety reasons, we have to look at, are there any cultural barriers, and do I have any misunderstandings or lack of understanding that could affect the treatment? So again, I go back to me and going, the default perspective, the default culture within my therapy room is the client's culture. I am needing to adapt. And so sometimes in this area, the goal is actually for me to be able to offer effective therapy. The client's willing to work with me, but I have to start assessing my own understanding of culture so that I can effectively communicate with this client and effectively deliver services. So remember that unaccompanied migrant children's situation are often tenuous. I think I already read this. And so in looking at treatment goals and interventions as well, you know, we have so here's a little Easter egg. We have the ecological validity model. I highly recommend that you look it up. That really goes through different areas where you can assess culture. We actually have one of our other modules actually teaches that. I think it might be the next week's one, if I'm not mistaken. And being able to assess that using an effective model can help us adapt it as well, you know. And so in the following modules that you're going to see next week and the week after, you can see how exactly we do that much more specifically than what I'm going to talk about today. All right, so cultural concepts of distress. So if you have a DSM-5, there's a little secret at the back. It's a very magical secret because it talks all about cultural concepts of distress. It lays out the cultural formulation interview in a wonderful way to help give you tools to actually use to begin to assess this, you know, concepts of distress. I highly recommend you look at that. Most people, in terms of the DSM-5, it's this big, so you just find the, like, you know, the diagnosis you're looking for, then you put it away. Nobody ever goes to the back of the book. I'm recommending it because, in my opinion, it's the best part of the book. Totally biased though. So as we're looking at the cultural concepts of distress, they're expressed through 3 concepts. First of all, cultural syndromes, groups of symptoms that co-occur among individuals in specific cultural groups, communities, and contexts. And so often, you know, well, and I think I'm going to talk a little bit more about this in a minute, so I'll just go over this, just wanted to check. Cultural idioms of distress, ways that symptoms are expressed which provide a collective shared way of experiencing and talking about personal and social concerns. You know, right now I'm thinking about the pandemic, you know, how we talk about COVID. You know, there are certain ways based on your work environment. Now I work in a hospital. And so in a hospital, there's certain ways we talk about COVID. And then, you know, talking to my family, we use different language. We pay attention to different things. You know, that's part of our different cultures, you know, professional culture versus my own personal family culture, you know, of talking about our concerns about it. And then cultural explanations or perceived causes, labels, attributions, or features of an explanatory model that indicate culturally recognized meaning or etiology of symptoms, illness, or distress. In other words, it's the why. Yeah, I've been seeing this. So sometimes I'll think about the pandemic right now, you know, in terms of COVID, and looking at, I've been seeing some what I'm going to call COVID shaming. You know, you find out a friend has it or somebody that you knew, and instantly you know what, they never wore a mask, that's why. Or, you know what, they said these particular things about COVID, you know what, they were destined to get it. But we do this with all illnesses. That's just, you know, one example. Think about getting a cold. You know, going outside without a coat does not give it. It doesn't make scientific sense. You know, that's where the germs, they come in you and you now get a cold. You know, however, we certainly attribute going outside without a coat to getting a cold. That's cultural. That's part of a cultural attribution of why we get sick. Some people get sick and it's oh, well, you didn't take care of yourself, or, well, maybe you weren't that nice of a person. So, maybe that's why you get sick. And when we can't figure that out, we look for it. Why in the world, why would you get cancer of all people? You're such a good person. So that's what that is. It's understanding those cultural explanations. And I'm going to talk a little bit more about those now. So when we think about cultural concepts of distress, although a majority of Latino children in the US have been socialized to some extent into American beliefs around psychological well-being, it's still important to understand these different interpretations of distress, particularly since so many Latinos live in mixed status and multi-generational families where parents, grandparents, and other family members may have varying perspectives on mental health issues. And so, and we're looking, I know in this talk, we're talking a lot about Latino children, but this is everybody. This is individuals who have immigrated, individuals who are in different levels of acculturation. And so as we think about psychological well-being, there can be different interpretations of distress. We think about some families where, if someone was feeling sad, I actually just had a group on this, actually it was just yesterday. I was leading a group, and this is of adult men. And we were talking about one of the members had been feeling tearful, and he's like, I don't know why I'm crying. He's like, I haven't cried in years, and all of a sudden it just came upon me, and and all of a sudden we started talking around the room just about crying and what crying meant, and when it's appropriate and when it's not appropriate, and especially as men, what they've learned about crying and what they've been told about crying throughout their life. And so, and this, is very, very much according to, I was, thinking very much according to their cultures, of some individuals who had grown up in kind of a much more nurturing environment where, people expressed emotions. And so they were much more comfortable with the idea of crying, as opposed to other, other individuals, families of origin where, no, I was told to suck it up. My dad would call me names if he'd see me cry. And those things come with us. But they're also affected by what's going on in the community, what we see on social media. When we see strong leaders that are able to demonstrate emotion, they're able to demonstrate sadness or even anger in an appropriate way, our children are taking these things in and making it a part of their norm, as they absorb it. But it's also knowing that, when the kids we're working with go home, they may understand that mental health is a good thing, that we want to express our emotions. We're doing much more emotional education within the schools. However, their parents might not be on the same page, and that can definitely be an issue. All right. So there are a few cultural syndromes, and these are in the DSM-5. So if you ever want to take a look at them, but here are some common cultural syndromes that individuals express. Man, that kid's kind of scary. I'm looking at that picture. So ataque de nervios, it's characterized by symptoms of intense emotional upset, including anxiety, screaming, shouting, crying, trembling, may include verbal and physical aggression. There may be dissociative experiences, seizure-like or fainting episodes, and suicidal gestures are prominent in some ataques, but absent in others. And mostly it occurs as a direct exposure to a stressful event relating to a family. Now, my experience with this, because I work with individuals who have a very diverse acculturation status, and sometimes I see this, but the client might not call it by name, and so there are some clients where they know what it is, they call it by name, but other individuals, especially if they're kind of in that cross acculturation, movement, where they know what it is, but they can't verbalize a name for it. It's just like, oh, this is just what happens, this is just how I feel, or this is how I express this. And so I think it's really important not to get stuck with the terms. It's good to know the terms, but also we're looking for that constellation of symptoms to help us understand what is actually occurring here. Other cultural idioms. Hispanic and Latino persons may use expressions that are consistent with the cultural syndromes they experience. For example, nervios, a general state of vulnerability to stressful life experiences and to difficult life circumstances, starts with a persistent idea that's stuck. The individual may find it difficult to think about other things, or they may find their thoughts consistently returning to the idea. And so I was working with somebody the other day who they they had decided that they were feeling old. I think they're about my age. So perhaps they were old, I don't know, depends on where you are. And so they had decided that they were going to start participating in an exercise class, and in that they had started to really, get stuck in their head that this is how I'm going to live a long life. This class, I just have to do it. If I don't, because they have a very sedentary lifestyle, if I don't go and do it, something bad's going to happen. This is keeping me moving forward, is keeping me healthy, and they reported a very, very helpful thing, as it's, just helping them cope with that kind of general fear of, well, what's going to happen, what's going to happen in the future, until the day that they missed. They woke up late and they missed it. And from that, they were describing this to me. And from the moment they woke up and they're like, oh, I missed it. And what they were telling me, all of a sudden they felt incredibly stressed and they started to worry just about what was going to happen that day, of just am I going to be okay? Am I going to, and actually, and I don't want to say it was humorous, but not within the hour of getting out of bed, they actually twisted their back and thus did have a major injury. And the individual, as they were processing this and talking about it, it was because I didn't attend this exercise class. If I would have attended that exercise class, I wouldn't have injured my back and everything would have been okay. And in this, and I'm thinking, I was watching this just kind of persistent idea that this particular class is what's keeping me healthy, that I need exercise, which is true, totally true. Individual needs exercise, it's good for them, it's healthy for them, but then just the anxiety of getting old, which is what it really was, the anxiety of aging, the anxiety of moving forward in life, that they started to get just this idea that this is what I must do. And so there was significant consequences, and I'm imagining physically what probably actually happened is they were getting tense, due to the missing of it, and, and hurt themselves in that just because of the tension there, but they were really struggling to think of anything else and move past it until we were able to kind of unpack it, and talk about what that means and even what aging means to them. And so in terms of nervios, children and adolescents, and I gotta say adults as well, could experience headaches. I like the term brain aches, that's fun. Irritability, stomach disturbances, sleep difficulties, nervousness, easy tearfulness, inability to concentrate, trembling, tingling sensations, and dizziness. And what I'd like to draw your attention to is a lot of these have multiple possible diagnoses. And so many of those, when we're looking at children, or again, adolescents and adults, you see a couple of these, in terms of dizziness, tingling sensations, headaches. Maybe there's something going on, with the brain, maybe there's a pinched nerve somewhere. Some of these other things, could be contributed to indigestion. However, it's this constellation of symptoms and our understanding of what else is going on. Always, I totally recommend, rule out, see their pediatrician, see your medical doctor to get, any major illnesses ruled out. However, at the same time, as clinicians, we need to be able to identify this. And in some ways, how I like to put it is take ownership of this may be some symptoms of anxiety, maybe some symptoms of nervios, that we're looking at that need to be treated and are best treated, through, psychological treatment. So just keeping an eye out for that. With a lot of these idioms of distress, we're looking at constellations of symptoms. So it's not just one thing, it's looking at things and how they're interacting with each other, just to note that. Also, we have Latino cultural explanations for an illness. And I told you a little bit about this a minute ago, of just why do good people get sick, So susto is attributed to a frightening event that causes the soul to leave the body and results in unhappiness and sickness, as well as difficulties functioning in key roles. This syndrome may occur with somatic symptoms, and so these are things that when you're, as you're talking about, well, why is this happening? An event like this might have the attribution there. Prevalent among Latinos living in the US that are from Mexico, Central America, and South America. And of course, we have related DSM-5 diagnoses. And so in real life, as we're looking and, we know, because we've all attended this training now, these cultural explanations. And so looking at how it's translated into Western medicine sometimes can be helpful, especially if you're you're working with somebody new, you're looking at their file, and as you're talking to them and you're aware of just some of the cultural explanations that you're hearing from the client, being able to go back into the actual chart or the documentation you have, you may see these particular diagnoses. And when we're talking about the DSM-5, sometimes it's a list of, here's your criteria and here's what we call it. In some ways it's a little bit of a dictionary, a very fancy one, but it tells us how we're going to talk to each other about these particular constellations of symptoms. And so you may see major depressive disorder, PTSD, or other trauma, and also you may see somatic symptom disorders of individuals experiencing things, physical things that have no, actual origin, of anything bodily. And but that's how we are used to talking about it. But in addition to noting those in your treatment and using your clinical, judgment, I also think about this in terms of when I have to explain it to the family. Part of our role as treatment providers, whether you're working in a school, outpatient, is to be able to translate some of the clinical vocabulary to what the family can understand, to their own way of speaking to things, and so just understanding how they might see it is very important. All right, in addition, so SUSTO, 3 syndromic types of SUSTO have been identified, and each have a different relationship with psychiatric diagnosis. First one is an interpersonal SUSTO caused by feelings of loss, abandonment, not being loved by family, with the accompanying symptoms of sadness, poor self-image, suicidal ideation. They seem to be closely related to major depressive disorder. Now, a little while ago, we were talking about the migrant population, and seeing that many of the just routine things that happen in that process are very much connected to this idea, and so we may be seeing some of those symptoms. When SUSTO results from a traumatic event that played a major role in shaping symptoms and an emotional processing of the experience, PTSD appeared more appropriate. So often we'll see the diagnosis of PTSD, but it's our role, being culturally aware, to go back to, find out what the meaning was behind this trauma and what meaning the individual took from that, especially cultural meanings that may affect them and may not be translated well for individuals who are not culturally aware. SUSTO was also characterized by various recurrent somatic symptoms, and it was thought to resemble a somatic symptom disorder. And so looking at that and looking how those symptoms may play out as well, is very important. Mal de ojo, it's considered an illness translated by making eye contact with the recipient, with someone, as it is received through the eyes of the intended recipient. The instigator frequently covets the victim child. When the illness is passed, it heats the blood of the victim, causing multiple gastrointestinal problems. And so in this one, you may be seeing somebody with, upset stomach. I know I've worked with a lot of people that they tell me they have no problems, no anxiety, no depression, but they have multiple health issues. And so looking at that, I don't challenge them, but I kind of tuck it in the back and go, okay, this individual's had a heart attack. This individual has IBS. This individual has had multiple long-term gastrointestinal issues. And I can see evidence of what I might call anxiety, or maybe attributed to another, psychological issue. And so it's, being able to understand that and make that connection of doing a full, thorough, tell me about how you feel physically, can be very helpful in terms of understanding where the individual is expressing their emotion. All right. So schools are considered a safe place to receive mental health services. Most parents prefer that the children and youth to receive mental health services in the school setting. Schools are generally trusted, generally, it depends on the school system. But I know in my community, we do have an entire organization that goes into the school, and that's where they perform all of their counseling services. School has set aside a little area for them, and that way the individual, the child after school or maybe during lunch can participate in outpatient counseling sessions inside that school environment, which has made it a lot easier. When we're talking about barriers to treatment, that has made it a lot easier. And additionally, when the parents are asked if they'd be acceptable, if that's acceptable, remembering the personalismo value that we have and seeing trusted teachers, trusted counselors recommending this and knowing it's happening within the school can present us with a wonderful opportunity to work with children that there may be another stigma going to an outpatient provider that you don't know. The idioms of wellness and resilience can be used to identify collective and individual areas of coping, social support, and intervention. And so, you know, when we look at illness, I mentioned earlier that the opposite, you know, or the dichotomous opposite of illness is wellness, you know. And so we can't understand one without the other, you know. And so as you look at and you think about even in your own mind, what is wellness? How do you know you're well? What are the things that you particularly look for to go, I'm well today? Then, you know, in many ways, the opposite of that is the I'm not well today, you know, and therefore I may be ill, you know, and I know illness, you know, sometimes it's, you know, illness is like, well, I can't function. I'm not, you know, I'm sick. But again, if we don't have wellness, you know, and it may be more of a continuum, you know, then all of a sudden we reflect that on, it reflects upon illness. So and so looking at that, wellness isn't just about my body feels good today. It's also about, you know, it's the physical body, it's the emotional. Do I feel emotionally and psychologically well? It's the social. Are my social relationships healthy? You know, do I have relationships that are supportive to me? Educational or employment, you know, am I doing well? Do I have a plan? Am I increasing my learning? And also spiritual, you know, as we're looking at how do I feel in terms of my purpose? I define spiritual, you know, as knowing one's purpose, knowing one's values. It may also be attached to, you know, religious practices, you know, and a higher power. But it's that, are we well in that area where we can verbalize those and we feel connected to doing what our values are, you know? And so this, understanding this and using that to look at coping, social support, and intervention can be very helpful. You know, and again, I'll note that I recommend looking back to the DSM-5 because it has a whole cultural formulation interview that can help you with that topic. So here's a little bit of, here's a case study that we can apply to. So 4 years ago, well, I'm going to read it because otherwise it's kind of quiet over here. So 4 years ago, 4 years ago, 15-year-old Veronica moved with her parents and Mario and two siblings from Mexico City to San Diego, California, after a previous migration from a rural town to the Mexican capital. Estela's oldest sister, Lucia, had spearheaded the migration with her own family by 1 year. Veronica lived in a rental small apartment in a middle-class neighborhood. She goes to a public school. Both parents are overworked due to the limited income. Veronica visits the Catholic Church frequently with her family. She was also a model student in Mexico and in the US. She is part of top of her class, despite the new language and cultural stress. She informed, Yo quiero ser alguien. I want to be somebody. One of the major stressors that Veronica is dealing with include being involved in a love triangle where she was in competition with her female cousin. You know, and so we have this that we're looking at, you know, just understanding how the case is. So a couple more notes. She feels anxious about losing her friendships with her cousin and losing her roommate with 21-year-old Raul. Her parents had difficulties providing details of the episodes in which the girl had epileptic-like trembling, rolling of her eyes, sometimes foaming at the mouth, and screams. Veronica's symptoms last for up to a half hour and stop on their own. Medical evaluation failed to uncover any organic issues, and the school social worker called her parents in order to provide mental health services to Veronica. Yeah, and so hopefully, you know, you're beginning to, you know, just with that constellation of symptoms, you're beginning to see, you know, that there are definitely some cultural syndromes that are happening there. So some things that I'd like you to think about as you're looking at this case, you know, first of all, based on the example, you know, identify how the cultural expressions of distress may be impacting her. So first of all, what would you like to know about the client that you don't already know? You know, so you can think about that for a minute. How might an understanding of cultural syndromes help the assessment and treatment plan for Veronica? How might an understanding of cultural idioms of distress help Veronica in treatment? And how might cultural explanations of illness impact Veronica's commitment and motivation for treatment? And so I'm going to go back, you know, to this. So imagine you're working wherever you work now, and you're talking to the family, and this is what they tell you about Veronica. You know, I know without the knowledge of, you know, what we've just talked about, you know, about here, even though I've been doing this a long time, without that knowledge, I would be referring them back to their, you know, their primary care provider. You know, because this, you know, looks very, very physical to me. You know, she's talking about feeling anxious. We go back one. There's obviously a lot of stress within the family. There's obviously a lot of loss and a lot of conflict. However, then when the parents start telling me about these symptoms, that would be a game stopper for me. I'd be looking and it's like, okay, I have no idea. Maybe they need some sort of evaluation, and I would send it back to the PCP, who may also be looking at this. I'm sure they'd run some tests, look at this. However, with this understanding, with the, and being able to ask the family about, well, what do you attribute her symptoms to? What is your understanding of why this happened? And, so thinking about the CFI, the cultural formulation interview, there's some nice questions there of just, when did she start having this problem? Asking different family members why they believe it's happening, what they believe would fix it, can really give us cultural insight so that we can better understand this, we can better help Veronica. Now, I know in my personal practice, I would still probably refer her to the doctor just to rule out anything specific. However, I wouldn't be dependent on that, on a physical doctor's diagnosis, because I have a full understanding of the mental health issues that we're looking at here, and because I understand those cultural syndromes. And so in terms of what I'd like to know a little more about if it's happened before, I'd use the CFI in terms of other cultural knowledge, knowledge about the family. I just talked about how those understanding the syndromes could help me to see those syndromes, those symptoms in a context, and that might provide me guidance for treatment. To have good treatment, we have to have, good assessment. And so that would help there. And then also, how might cultural explanations of illness impact Veronica's commitment and motivation? And I think this is one of the most important things, because when we sit down with our client, and remember, like I said, the default culture in the room is the client's. Default language in the room is the client's. I'm working to adjust them, adjust to them, my own treatment, that I'm providing to them. And so in this, and understanding where they're coming from culturally, I can then change the way I do things, change my techniques, change my approach to be able to include this, in some of those treatment interventions and some of those goals, and so that's how we're looking at this. All right. So I believe I saw that there were a few questions, so I'll pause right now. And so let's see here. Do we have any questions? I'll ask my moderators.
We do have a lot of comments.
Okay.
Let me see if there's any specific questions, because I haven't seen one in the last ones.
Okay, good. Well, and if you do have any questions, you can type them in.
I don't see any questions, like particular questions. We do have a couple of comments on what different topics that you've been talking about. For example, one says, when we set up the peer support groups in the school system in Charlotte, North Carolina in '89, we discovered how prayer could be used in the group meeting room without violating federal laws. The students of many cultural backgrounds began to change.
Yeah. Yeah, and I love that. I think that's a great example of, being very, identifying what the particular students need, what that group needs. That sounds wonderful.
And then we just received a question. It says, how would you handle making the mandated report?
So mandated report, are we talking about the one with Veronica regarding her relationship? And so that one can be very, very difficult. You're right. And so I think, and I just pulled it up so anyone, can see the screen. Whenever I am in a situation like this, which I have been, it always starts at the very beginning, that preventative work, in terms of I'm always very, very clear with my, my clients of, what, here's how far my confidentiality stretches. you know, just in terms of, you know, how, if anyone is abusing you, if you threaten to harm yourself or someone else, then I must report it. And so in this, as they're talking about this, I'm going to have that discussion of, you know, just my concerns and my need to report based on the fact that this is an adult and she's 15 and with a 21-year-old here, which does make it much more complicated. And it's something that, because with mandated reporting, we can't screen, you know, and so even though I might look and go, oh, you know what, the parents are okay with it, everyone's okay with it, different culture, we can't screen, you know, with mandated reporting. And so unfortunately, then there would be a discussion just of what we're looking at and, you know, what has to happen by law. I've had this happen and I was able to maintain the relationship with the clients, because I know a lot of people think it's like the second you report something, it's over. But if it's done well, you know, if it's done within that context of, hey, these are the parameters that I have, this is the law I have to follow, and these are the laws within this state, you know, I've gotten a lot farther of just being open and honest, but also recognizing that, you know, I don't see that there's any bad intentions, you know, and helping them kind of navigate that, you know. So I think that's usually how I've approached it in the past. Those are, let me tell you, they're hard conversations because you know, once you call it in, it's out of your hands. So yeah, thank you for that question.
Thank you, Michelle. Since we're a little bit past time, I'm gonna go ahead and make one last question we just received, which I think it's like very on point. And then after that, we can just wrap it up.
Okay, great.
It says, I wonder if you have any advice for collaborating with other providers, medical, DFCS, etc., who might be less inclined to take cultural considerations into account.
Yeah. So I love this question because, so I'm a social worker. So, you know, we're like the collies of the professional world. We just keep running around each other, people until they're together. And I think I have not met any clinicians or healthcare providers who are like, we don't care about culture. Usually the language is, we think we're doing everything we can, or we don't see any gaps. And I think, so some of our helping our colleagues change is giving them a vocabulary to understand, you know. And so in that, I know a lot of the providers that I work with, you know, first of all, especially as an outpatient provider, I work to actually meet with the hospitals. You know, some of it's for referral. You know, hey, can I come to your hospital, talk during a, you know, a staff meeting, just a very small presentation of what I do, you know, and maybe bring in culture and just tell them, hey, this is kind of what I do, you know, and we can talk about that, you know. And so that's one end on a professional way. But in another way, it's really making sure to be the advocate that when you are collaborating with someone else, to be that, I got one thing to say, and to bring in that cultural part. And because I know sometimes we are in circumstances where you don't want to offend anybody, but we're advocating for our clients. So sometimes it's just being that, you know, just repetition of, you know, hey, you know, what do you think? I do know it's, if we yell at people, if we shame them into, hey, this isn't culturally appropriate, they won't, you know, change. But when we approach it as a, let me educate you, let me help you understand, or here's some of my ideas of what might be affecting this client, we can really help kind of bridge that gap so that our fellow providers can, you know, kind of increase their own cultural knowledge. So yeah, thank you for that question.
Thank you, Michelle. We don't have any more questions or anything. I gotta say, I'm not sure why. I'm looking at a QR code and a link on that. You're gonna receive an email with another link, so make sure you guys don't click on that one, because you're gonna receive an email after the webinar that is gonna have instructions regarding certificates as well, because I know everybody always ask about those. With that said, I think that we can just say goodbye until next Wednesday, when we have our next part with Dr. Evans as well. So, Dr. Evans, I don't know if you want to say something before we go.
Yep, I look forward to the next one. I love the next module. It's one of the ones that, you know, excite me. So I hope to see everybody there.
Great. I hope everybody has a great afternoon. Thank you.